This conference will now be recorded.
No. Good morning, everyone. Today's class is on endocrinology in relation to reproduction. And specifically, we are going to talk about placental endocrinology and its relation to the reproduction and pregnancy. So, where endocrinology is actually necessary during pregnancy is in this following introduction. Endocrinology means hormones. These hormones are essential for maturation of Graafian follicle, ovulation, and maintenance of corpus luteum. For maturation of Graafian follicle, both FSH and minimal amount of LH, even estrogen is required. For ovulation, there is requirement of estrogen surge followed by LH surge, and the maintenance of corpus luteum is by after fertilization. The maintenance of corpus luteum is by HCG, which is synthesized by syncytial trophoblast. So for the maturation of Graafian follicle followed by ovulation, fertilization and maintenance of corpus luteum, these hormones are essential. Coming to the next one is placental transfer of pituitary ovarian function. The normal pituitary ovarian function of hormones is completely transferred to placenta, which becomes the main energy source of hormones during pregnancy. The third one is physiological changes that happens in endocrine glands during pregnancy. And during labor, estrogens and progesterones, the interaction between the estrogens and progesterones and their levels and their imbalance will cause onset of labor. And coming to finally, the lactation is maintained by prolactin hormone. So these are the main areas where endocrine function is actually necessary during pregnancy or during the reproductive function. So now we are dealing mostly with the placental endocrinology. That is the second part, placental endocrinology, where the pituitary ovarian endocrine function is getting transferred to placenta after fertilization and during pregnancy. So placental endocrinology usually starts by 6 to 8 weeks, where there is a transfer of functions of the corpus luteum to the placenta. This we call it as luteal placental shift, which acts temporarily as a new endocrine organ or the main powerhouse of the hormone production. Why we call it as temporary? Because this placental function is only during pregnancy, and after that it is getting switched to the again pituitary and ovarian function. Therefore, it is a temporary and the main powerhouse of the hormone production during pregnancy. So this transfer of functions of corpus luteum to the placenta is called as luteoplacental shift, which is going to happen by 8 weeks of gestation. What are the main placental hormones? So they are mainly protein hormones and steroid hormones. Steroid means like fats. So the common placental hormones are hypothalamic like hormones, which we call it as releasing hormones: corticotropin releasing hormone, gonadotropin releasing hormone, thyrotropin releasing hormone, and growth hormone releasing hormone. So these are hypothalamic hormones, and hormones like hypothalamic like hormones are going to get synthesized from cytotrophoblast and syncytiotrophoblasts of the placenta. The second set of hormones are pituitary-like hormones. The main pituitary-like hormones are adrenocorticotropic hormone, human chorionic gonadotropin, human chorionic thyrotropin, and human placental lactogen. So these are going to get synthesized from syncytiotrophoblasts of the placenta. I hope you know syncytiotrophoblasts and cytotrophoblastic cells of the placenta. So these are the main hormones. Among these, human chorionic gonadotropin and human placental lactogen are main. So other pregnancy related proteins like pregnancy associated plasma protein A, which is synthesized from syncytiotrophoblasts, relaxin from corpus luteum, decidua. Decidua is the endometrium, the specialized endometrium of the pregnant uterus, and placenta. Prolactin, which is again synthesized from decidua, and atrial natriuretic peptide from atrial myocyte, and early pregnancy factor from activated platelets of mother and ovaries, and other growth factors from the syncytiotrophoblasts. And the main steroid hormones are estrogens, progesterones, and cortisol. estrogen from fetoplacental unit, which we are going to learn in the future, in the later on slides, and progesterone before 6 weeks it is synthesized from corpus luteum, and where the luteal placental shift happens after 6 to 8 weeks. Therefore progesterone is synthesized from placenta after 6 to 8 weeks of gestation, and cortisol from decidua and adrenaline glands. So the prior hormones are protein hormones, and these three are the major steroid hormones which are synthesized from the placenta and which are going to help during the pregnancy. So we are going to learn about the main hormones which are actually necessary for this pregnancy. The first among which is human chorionic gonadotropin. This is a protein hormone. HCG is a glycoprotein with a molecular weight of 36,000 to 40,000 Daltons. It is chemically and functionally similar to LH, luteinizing hormone. Therefore, in reproductive medicine, we usually give HCG for ovulation as well, because LH, luteinizing hormone, is required for ovulation. LH hormone is required for ovulation. This LH surge is artificially maintained by HCG in reproductive medicine, because it is chemically and functionally similar to luteinizing hormone, which is secreted by pituitary. It consists of a hormone specific and non-specific parts. It is having two parts, alpha and beta. The alpha portion, which is composed of 92 amino acids, it is a non-specific part. Non-specific means there is similarity with other hormones as well. See, if you can see, luteinizing hormone, follicular stimulating hormone, and thyroid stimulating hormone, all these hormones will have this alpha 92 amino acid chain. So this is a non-specific part of human chorionic gonadotropin, and the specific part is made up of 145 amino acids, which we call it as beta chain. So this beta subunit is relatively unique to HCG. Therefore, for qualitative or quantitative measurement of HCG, we usually take beta subunit of HCG because it is only specific for HCG. If you take alpha, again it will have a cross reactivity with LH, FSH and TSH. So HCG is a protein hormone with molecular weight of 36,000 to 40,000 Daltons, which is similar to luteinizing hormone. It is having two parts, non-specific alpha and a specific beta. And alpha subunit, it is biochemically similar to FSH, LH and TSH, and beta subunit is relatively unique to HCG. And HCG's plasma T-half is 36 hours. So it is after secretion, it is visible in the blood for 36. That is having a plasma T-half of 36 hours. It is detected in maternal serum or urine as early as 8 to 2 days post fertilization. After fertilization, the HCG, we can detect HCG both in maternal serum or urine as by 8 to 10 days after fertilization. And this HCG hormone, it gets doubled every 2 days. I mean, that is every 48 hours. So this doubling time is also we use this doubling time for diagnosing ectopic or abortions or early pregnancy or live pregnancy. So the doubling time of HCG is very important. Just remember, it is 1.4 to 2 days. So every 48 hours, the value of HCG gets doubled. So blood and urine values usually reach maximum by 60 to 70 days of pregnancy. That is 100 to 200 international units per ml. If you see this, it will go up to 1 lakh to 2 lakhs international units per liter. Just remember this units, international units per. If you are writing in international units per liters, it goes up to 1 lakh to 2 lakhs, which is the maximum level. And you can see this level by 70 days of pregnancy. That means by 8 weeks. 8 weeks are around approximately 8 weeks of gestation. And after this peak, there is a slow fall reaching to 10 to 20 international units per milliliters between 100 to 130 days. Thereafter, it remains as a plateau. It remains constant throughout the pregnancy with a second peak at 32 weeks of gestation. Usually, after pregnancy, after termination of pregnancy, that is following delivery, HCG levels will become less or less than 2 within 2 weeks of delivery. So this is the graph. I'll show you the graph in the later slides. Usually, you can see this HCG as early as 8 to 9 days post fertilization, and whose levels usually rises constantly up to 100 to 200 international units per ml, or 1 lakh to 2 lakh international units per liter by 70 days of pregnancy. After that, it slowly falls to 10 to 20 international units per milliliters by 100 to 130 days. Later on, it remains constant. It goes in a plateau with a second peak at 32 weeks of gestation, and usually it disappears after 2 weeks following delivery. So this is the trend HCG follows. So what is the significance of HCG? So why you are more concentrating on HCG? Why you want to check HCG levels even in blood or plasma? So elevated levels of HCG you can see in multiple pregnancy, erythroblastosis fetalis, molar pregnancy, and Down syndrome. And lower levels in ectopic pregnancy, missed abortion, and Edwards syndrome. So this is the significance of calculating the HCG levels. So clinically, we apply these HCG levels by diagnosis of pregnancy. If you can see HCG or beta unit of HCG in urine or blood sample, you can diagnose a pregnancy, but you cannot locate a pregnancy. You can diagnose a pregnancy. It can be an ectopic. It can be an intrauterine gestation. So if you suspect an ectopic pregnancy, you better go for a doubling time. So after every 48 hours, you will go for a repeat HCG levels. If the level is increasing more than 66%, then it is a viable normal intrauterine pregnancy. For ectopic pregnancy, usually the rise is not seen. So after molar pregnancy, you can go, you can check this HCG levels for follow-up of a molar pregnancy. For a molar pregnancy, after evacuation, you follow up the patient with HCG levels until it goes below 2. And for the screening of anomalies, as we have already seen in the previous slide, for Down syndrome, HCG levels are elevated, and Edwards syndrome it is less. So this is the major clinical application of HCG values. So the main functions of HCGs are: it usually rescue and maintenance of corpus luteum till 6 weeks of pregnancy. This HCG is secreted by syncytial trophoblastic cells of the placenta or developing placenta, which usually maintains the function of corpus luteum till 6 weeks, because after which this function is taken over by the placenta, which is the main powerhouse of the endocrine during pregnancy. The second function is it stimulates Leydig cells of the male fetus. It stimulates the Leydig cells and it produces the testosterone, which indirectly helps in development of male external genitalia. It is also have a immunosuppressive activity, thereby it inhibits the immune rejection, because fetus is a combination of both maternal and paternal tissues and chromosomes. Because it is a foreign, paternal tissues or paternal chromosomes are foreign to mother, this immunorejection is inhibited by this immunosuppressive activities of certain hormones, among which HCG is one. Thereby the fetus, immunorejection of the fetus is inhibited by this HCG. HCG stimulates both adrenaline and placental steroidogenesis. As we have already, steroidogenesis, progesterone, estrogens, and cortisol. It stimulates thyroid because it is having a non-specific part, the alpha part, which usually stimulates the thyroid gland for secretion of TSH, because it has a resemblance with thyroid stimulating hormone as well. And it promotes secretion of relaxin from the corpus luteum. So these are the major functions of HCG. It is maintenance of corpus luteum till 6 weeks, where after 6 to 8 weeks the main function is transferred to placenta. It stimulates Leydig cells in male fetus and helps in the development of male external genitalia. It has an immunosuppressive activity, thereby it stops the immune rejection of the fetus, stimulates both adrenaline and placental steroidogenesis, stimulates maternal thyroid and it promotes secretion of relaxin. The second hormone, the second important hormone among protein hormones are human placental lactogen. This is also known as human chorionic somatomamotropin. This hormone is chemically and immunologically similar to pituitary growth hormone and prolactin. The previous one, HCG, is similar to luteinizing hormone. This hormone is similar to pituitary, GH, and prolactin. HPL, human placental lactogen, is first detected in maternal serum by 3rd week of gestation. HCG is detected by 8 to 9 days post fertilization. This you can first detect in maternal serum by 3rd week of gestation. And after after the 3rd week of gestation, the level progressively rises from 5 to 25 micrograms per milliliters until about 36 weeks. I'll show you in the graph in the later slide. HCG is having up to 70 days, it progressively rise, and then it slowly falls, then it maintains as a plateau, and then it is having a second peak at 32 weeks of gestation. But human placental lactogen, usually it starts by 3 weeks of gestation, and it progressively rises from 5 to 25 micrograms per milliliters until 36 weeks of gestation. So it is not having, this human placental lactogen is not having a fall or a peak. It is progressively rising. The plasma concentration is proportional to the placental mass. Why it is progressively rising? Because its plasma concentration is directly proportional to the placental mass. And the placental mass is gradually increases throughout the pregnancy until term. Thereby, the human placental lactogen level also rises progressively until 36 weeks of gestation. So the main functions are, human placental lactogen is having an antagonistic action to insulin. Therefore, in pregnancy, we'll call pregnancy as a diabetogenic state. Why? Because human placental lactogen, the hormone which is released or which is secreted from the placenta, is having a antagonistic action of insulin, and it promotes the transfer of glucose and amino acids to the fetus, and it helps in lipolysis, and mainly the fatty acids are used by mother, and amino acids and glucose is transferred to fetus preferentially. It is also having an angiogenic potency, which helps to develop fetal vasculature. So it promotes growth of breasts for lactation as well. So these are the main function. It is having an antagonistic action to insulin. It promotes transfer, like preferably it transfers glucose and amino acids to fetus, where mother uses fatty acids after lipolysis. It is having an angiogenic potency, and it helps in developing fetal vasculature. It promotes breast for lactation. The third one is pregnancy specific beta-1 glycoprotein. It is produced by trophoblastic cells, can be detected by 18 to 20 days after ovulation, and it's a potent immunosuppressor. Immunosuppressor is, again, it inhibits the immune rejection of the fetus. An early pregnancy factor, it's a protein produced by activated platelets and ovaries and other maternal tissues. Usually it is detected in the circulation. Sorry, it is detected in the circulation by 6 to 24 hours after conception, and it is also having an immunosuppressant. Both pregnancy specific beta-1 glycoprotein and early pregnancy factor are having immunosuppressant activities. The other growth factors, usually they have immunosuppressive activity. Paracrine means they act on cells which are close by, and they also have a steroidogenic properties. The growth factors include inhibin, activin, insulin like growth factor, transforming growth factor, and epidermal growth factor. Usually they are produced by syncytial trophoblast. The main protein hormones are HCG and human placental lactogen. And the last one is pregnancy associated plasma protein A, which acts as, again, immunosuppressant secreted by syncytial trophoblast, and whose level is actually used for detecting fetal anomalies. This pregnancy associated plasma protein A, usually it is used as a biomarker, biochemical marker, which is during the first trimester of the pregnancy. Usually it is used in double marker. Double marker, we usually do HCG and pregnancy associated plasma protein A, where the blood sample of the mother is taken during first trimester of pregnancy, and their levels are calculated. Low levels of pregnancy associated plasma protein A is associated with increased risk of preeclampsia and IUGR. So this we use it as a biochemical marker. Coming to the steroidal hormones. The main steroidal hormones are estrogen, progesterone, and cortisol. So we are dealing with estrogen and progesterone. So coming to the estrogen, in late pregnancy, qualitatively there is more amount of estriol among the three major estrogens. What are the three major estrogens? Estrone, estradiol, and estriol. Estriol is the major qualitatively it contributes to the major portion in the late pregnancy. So usually the site of production is the syncytial trophoblast. The placenta, syncytial trophoblast is the cells of the placenta. The placenta is an incomplete endocrine organ for the synthesis of estrogen as it is not capable of independent steroidogenesis. So the placenta is not having the precursors which are actually necessary for estrogen synthesis. Therefore, placenta goes with the incomplete endocrine organ in respect to synthesis of estrogen. So for steroidogenesis, usually it depends on precursors which are mainly derived from fetal and partly from the maternal sources. So this you can see in this figure. The precursors are cholesterols. For steroidogenesis, the precursors are cholesterols which are mainly derived from maternal, that is from mother, and mainly from fetal, and partly from maternal for estrogen synthesis. And finally, this cholesterol is going to get converted to pregnenolone sulfate, and here in adrenalins it is converted into pregnenolone sulfate, and in liver and adrenaline it is converted into dehydroepiandrosterone sulfate, and after hydroxylation it goes with 16 alpha hydroxy dehydroepiandrosterone sulfate. This 16 alpha hydroxy dehydroepiandrosterone sulfate goes to the placenta, and with the action of enzyme sulfatase 3-beta hydroxysteroid dehydrogenase and aromatase converted into estriol. Therefore, this 16 alpha hydroxy dehydroepiandrosterone sulfate, which is synthesized from the fetal part, majority of which is secreted from the synthesis and secreted from the fetal unit, is getting transferred to the placenta, and by the action of sulfatase, aromatase, and 3-beta hydroxy dehydrogenase enzymes is converted into estriol. This is the major pathway of biosynthesis of estrogen in pregnancy. So estriol, usually it is first detected at 9 weeks of gestation. It gradually increases from 0 to 0.05 nanograms per milliliter to 30 nanograms per milliliter by term. And low estriol levels usually indicate either fetal death, fetal anomalies like adrenaline atrophy, anencephalus, and molar pregnancy, placental sulfatase and aromatase deficiency. You can see in this picture, this enzyme deficiency also reduces the estriol levels. Therefore, low estriol levels usually seen in placental sulfatase and aromatase deficiency. So coming to progesterone, you can see in this picture, progesterone is usually secreted by the placenta, mainly from the maternal and some part from the fetal. So the main precursor is again cholesterol which is derived from the maternal and fetal units, which is getting transferred into pregnenolone and further into progesterone. Therefore, before 6 weeks of pregnancy, corpus luteum usually secretes this progesterone component like 17-hydroxyprogesterone, and following the development of trophoblast, progesterone is synthesized and secreted from the placenta. And the precursors from fetal origin are usually not necessary, as we've seen in estrogen production, because in fetal origin the liver and the adrenalins, you can see in this liver and the adrenaline is actually required for dehydroepiandrosterone sulfate, which is getting converted into 16 alpha hydroxy dehydroepiandrosterone sulfate, which is required for estriol synthesis, but this is not required for progesterone. Therefore, the fetal origin is not necessary. So daily production rate is 250 milligrams in a singleton pregnancy. After delivery, usually its level decreases rapidly and is not detectable after 1 day or 24 hours. So what is the significance of progesterone levels? Low progesterone levels usually goes with ectopic pregnancy or abortion, and high progesterone levels are seen in hydatidiform mole and Rh isoimmunization. So the functions of steroid hormones. The major steroid hormones are estrogen and progesterone, as we have already read. Estrogen usually causes the hypertrophy and hyperplasia of the uterine myometrium. You can see these steroid hormones are usually required for the physiological changes that happen in pregnancy, the major reproductive organs, and the breast. So the main reproductive organs, uterus, and the breast changes are going to happen due to steroid hormones. So estrogen usually causes hypertrophy and hyperplasia of myometrium of the uterus, with increasing the accommodation capacity and the blood flow of uterus. So with the progression of the pregnancy and with the growing fetus, the fetus should get accommodated in the uterus, whose size is maintained or whose size is increased by myocyte hypertrophy and hyperplasia due to estrogens. And with the increase in uterine size, the blood flow of the uterus also should increase proportionately to maintain the blood supply to the growing uterus and the fetus. The second one is progesterone. Along with estrogen, it stimulates the growth of uterus and causes the decidual changes in the endometrium. As I've already said in the earlier topic, the specialized endometrium of the pregnancy is called as decidua, which is required for the proper implantation of the growing fetus, and progesterone also inhibits the myometrial contraction. So coming to the breast changes, the hypertrophy and proliferation of the ductal system is under the influence of estrogen, while those of lobular and alveolar system is due to combined effect of estrogen and progesterone. So the ductal system by estrogen and lobular alveolar system by estrogen and progesterone. So both the steroid hormones are required for adaptations of physiological changes of various maternal organ, which constantly increase in demand of the growing fetus, as I have already said. And progesterone usually maintains the quiescence. Quiescence is the quiet state of the uterus. The uterus usually during the pregnancy, it shouldn't get contracted, because premature contractions will cause premature labor and delivery of a premature neonate. Therefore, progesterone maintains this quiescence of the uterus during the pregnancy, and estrogen sensitizes the myometrium to oxytocin and prostaglandins in the later parts of the pregnancy, like at term or after the term. So estrogen and progesterone usually have an antagonistic action in maintaining uterine quiescence. Progesterone maintains uterine quietness, and estrogen promotes the myometrium or sensitizes the myometrium to oxytocin and prostaglandin during term, which actually starts the labor pain. And progesterone along with HCG and cortisol inhibits the tissue reaction. Again, progesterone is having a immunosuppressant action as well, along with HCG and cortisol, which helps in inhibiting the rejection of the conceptus and protects the fetus. So these are the various levels of hormones. This red one is HCG. You can see by 70 days, it is getting peak. It goes up to 100 to 200 international units per ml, or 1 lakh to 2 lakhs international units per liter. After that, it slowly falls. It slowly falls, and it is maintained at 10, about 10. And again, the second peak at 32 weeks of gestation. This red one in the graph depicts the HCG levels throughout pregnancy. So the second one is human placental lactogen. Human placental lactogen usually starts by 3rd week, and it goes progressively, it increases up to 36 weeks of gestation. It goes from 5 to 25. This is the human placental lactogen. And this progesterone and estrogens also increase throughout the pregnancy. So finally, the relaxin, it has been demonstrated in human corpus luteum, decidua, and placenta. It's structurally similar to insulin and insulin-like growth factor. It rises in maternal circulation as in early pregnancy, and attributed to secretion by the corpus luteum, and whose levels parallel those seen for HCG. Relaxin along with rising progesterone levels act on myometrial smooth muscle to promote uterine relaxation and maintains the quiescence, which is observed in the pregnancy. So this is the major part of today's class, the placental endocrinology and the hormones which are secreted by placenta, which are necessary for maintenance of pregnancy and to start the labor pains as well. And the common changes which you usually see in endocrine glands during pregnancy are, in thyroid gland, usually thyroid gland shows a hyperplasia and slight enlargement of the gland. You see the maternal serum iodine levels usually falls due to increased GFR and increased increased excretion of iodine through kidneys and transplacental shift to the fetus. So some part of the maternal iodine is going to the fetus and some part is getting excreted through kidneys. Thereby, maternal serum iodine levels usually falls. Therefore, you have to advise a pregnant woman to take iodine. Intake of iodine should be increased from 100 to 200 micrograms per day. There is increased basal metabolic rate in pregnancy due to increased maternal and fetal oxygen need. Increased serum protein-bound iodine and thyroxine-bound globulin due to estrogen stimulation. Due to estrogen, there is increased globulin and there is increased protein-bound iodine. Therefore, the free levels of thyroxine is reduced. Thereby, it increases the TSH values. So, since increase in thyroid binding globulin dependent on estrogen, a failure of to increase indicate estrogen, fetal compromise is seen. Coming to adrenaline, there is slight enlargement of adrenaline cortex, thickness of zona fasciculata, and significant increase in serum levels of corticotropin releasing hormone and ACTH, aldosterone, and deoxycorticosterone, corticosteroid binding globulin, cortisol, and free cortisol. All these hormones are increased during pregnancy. Due to this hypercortisolism in pregnancy, increased placental cortisol half-life and delayed clearance from kidneys. Why these hormones are at increased levels? Because there is decreased clearance and increased plasma half-life of the cortisol. So coming to parathyroid hormones, they increase progressively throughout the pregnancy. Parathyroid glands increase in size in pregnancy, which causes an increase in parathormone and calcitonin levels. Calcium level decrease in pregnancy, but ionized calcium, which is a main trigger for parathormone, decreases only slightly. Thereby, there is the parathormone hormone also reduces slightly. So calcitonin usually antagonizes the parathormone hormone and vitamin D, and its level increases, which serve as a maternal skeleton protection, and thereby it also helps in pregnancy and lactation. Parathyroid hormone does not cross placenta, but calcium ions do cross against a concentration gradient. Coming to pituitary, it enlarges during pregnancy. This does not appear to be associated with any pressure on optic chiasma or any clinical features. Level of almost all pituitary hormones are found to rise in pregnancy. Growth hormone increases to a small extent, which couples with human placental lactogen and makes pregnancy a diabetogenic state. And because human placental lactogen, as we have already read, is having a similarity with growth hormone and prolactin increases tremendously, and this ensures lactation. And pituitary gonadotropins are low due to elevated estrogen levels. Because steroid hormones, estrogen and progesterone are high, pituitary gonadotropins are at low levels. ADH and oxytocin steadily increase in pregnancy. This is one clinical aspect. Sheehan syndrome, it's a postpartum hypopituitarism. It's directly related to hypovolemia. If the patient is getting into postpartum hemorrhage, there is loss of intravascular fluid and intravascular even blood components as well. It is directly related to hypovolemia due to obstetric hemorrhage accompanied by vasospasm of the pituitary vasculature. Due to hypovolemia, there is a vasospasm of pituitary vasculature. Thereby, there is a loss of anterior pituitary hormone, but loss of posterior pituitary is uncommon. The patient, after recovering from the hemorrhage, usually presents with failure to lactate, prolonged postpartum amenorrhea, hypothyroidism, and persistent hypotension. So she will need complete replacement of all these hormones. So pancreas, pregnancy is associated with hyperinsulinemia and insulin resistance. This is due to human placental lactogen and other steroidal hormones like cortisol, estrogen, and progesterone. There is an accelerating fasting hypoglycemia and prolonged postprandial hypoglycemia. Pregnancy is a diabetogenic state. So endocrine control of lactation goes with 4 steps. Mammogenesis, that is preparation of the breast. Lactogenesis, synthesis and secretion of the breast milk by alveoli. Galactokinesis is ejection reflex, and galactopoiesis is maintenance of lactation. This is the overall picture. The mammogenesis, which is under the control of progesterone, estrogen, prolactin, adrenaline, steroids, and growth hormone. Mammogenesis is the preparation of the breast. Lactogenesis is the synthesis of milk into the alveolar system. So this is mainly controlled by prolactin, thyroid, like glucocorticoids, growth hormone, and insulin. And after that, the ejection reflex, which is called as galactokinesis, ejection of milk, and galactopoiesis due to sucking and prolactin. So these are the major endocrine functions related to lactation. Any doubts? So we'll end the session for today.